we're going to go over to the next slide, and we're going to fill this back in. So now we're going to go over it together. Come on, you sucker. Okay, here we go. Okay, is that a little bit bigger for you guys?
Yeah.
Sorry about that.
Yeah.
Okay, so eyes. What are the 4 scales for eyes? Does anyone remember?
The pupil.
Like spontaneous.
Yep, spontaneous was one of them.
And then to sound.
Yep, they to voice. Yep, they respond to your voice.
To touch.
To pain.
To pain, okay. And then no response. And then also not testable for any of the categories.
Yeah, and then none, right? So if it's 1, here's the way to remember 1. 1 is none, right? And the top number 6 and or 5 or 4, those are they respond appropriately, right? Respond appropriately, not respond appropriately, and then it degradates from there. And then 1 is always none. Are we? And then the middle stuff is it degradates from totally aware and spontaneous and everything's good to they can't respond at all. So that might make it a little bit easier for you guys to remember those.
Yeah.
Okay, so what's the next one? Verbal. Who wants to take verbal? And it can't be Alex because he already answered eyes. Alex, you're off the hook.
Okay, so
that's what I've been waiting for.
Verbal means they either answer every question that we ask correctly, like we ask their name. 5,
right? That's 5. Perfect.
Their name and their time of the day, what day of the day, what time of the day is today, and the name of the president. And that's when it's spontaneous.
Yeah, that's normal. Yep, they're totally aware. They answer appropriately.
Alert and oriented. Yeah.
Totally
and then you ask them, like they could say the time, but then they don't have answer for other questions, or they give you the incorrect. And then sometimes you just ask them a question, they just look at you like, what are you talking about?
Yeah, that's confused, right? They can talk to you, but when you ask a question, you say, hey, do you know where you're at? And they're clearly laying on the side of the road, and they say they're at home in bed, right? They're clearly confused. And so that would be confused, right?
Yeah.
Okay, so what's the next one?
And they're just completely silent. And, they answer you wrong questions.
Yeah, inappropriate words, right? They just, again, you ask them who the president of the United States is, and they say, my dog's name is Spot.
Yeah.
They're totally not answering appropriately.
Yep.
And then, what's the next one?
For verbal?
Yeah, so there's one more. So it's number 2. And number 2 would be...
They answer partially.
Yeah, they don't even give words anymore. Now it's just pain noises.
Word salad, yes.
Yeah, it's just pain noises. And then obviously 1 is none.
Yeah.
Okay, Addison, you're up last. Take motor.
So number 6 is when someone follows what you say.
Yep, follows commands appropriately. Yep.
5 is they can miss. Right?
Yeah, they can localize their own pain, which means they can tell you where it hurts.
Okay. 4 is withdraws from the pain.
Yep, they withdraw appropriately. That's correct.
And then 3 is the abdominal flexion, and 2 is abdominal extension. So
flexion and extension abdominals, that means to lean forward is flexion, and extension is to lean back and arch their back, okay? So they're giving us the anatomically correct thing, but sometimes it's easier to remember what they're talking about. Does that make sense? So don't get confused. If you hear abdominal extension or they're arching their back, that it would be a 2. If they're flexing forward, that's a 3.
Okay.
Okay, then the last one, always 1 is always what?
None.
None. 1 is always none. Okay, here we go. You guys ready? We're moving on. So question number 1, I got some review questions. What are the 3 components of the Glasgow-Coma scale? 1, eye motor and memory. 2, eye motor and pain. And 3, eye motor verbal. Or eye verbal pain. Motor. What was that?
Eye motor pain.
Eyes verbal and motor.
Eyes, verbal, and motor. For Alex, what about you, Addison? What do you think?
It's eyes, verbal.
Verbal.
Okay, here we go. Can you see it spinning? It's number 3. Eyes, motor, eyes, verbal, and motor.
Oh, okay.
You're okay. It's going to get harder. So those are 2 that got it right. It's going to be harder. Question number 8, or for us, it's number 2. You are called to see a patient who has fallen through a plate glass door. As you approach the patient, you observe that their eyes are extremely swollen and they are unable to open them. How would you record the eye component of this on the Glasgow Coma scale? 1, none. 2, to pain. And 3, eyes are not testable or NT.
The last one, they're not testable.
They're not
if
testable,
swollen
yeah.
shut.
That is appropriate. They are not testable. Can you see that getting bigger on your screen?
Mm-hmm. Yes.
Yeah.
I added some fun tonight. I added some little flair, so I hope you guys hope that makes us not suck as much. Okay, last one. If you were told by a colleague that their assessment of a patient's Glasgow Coma scale was E2, V3, M5, how would you interpret this? Now, for those of you who have your notes out, we're on page number 1. Pull your notes out and look this up. I want to make sure that we do this appropriately. Okay? So look at it. They break it down by scale. So eyes are 2. So what's eyes? Eyes 2 would be what?
I have to open my notes. I'm
To
on the
pain.
computer.
Yeah, to pain.
To pain, right? So eyes are pain. They're oriented to pain. V3 would be what?
Inappropriate words.
Inappropriate words. Hold, give me 1 second, guys. And then what's number 3? Somebody read out number 3.
M5 is that'd be localizes pain.
So let's read the answers. So Addison, will you read the first one?
Yeah. Eyes open to sound. They are oriented and are able to obey commands.
Yep. Okay, that's that one. The patient's eyes open to pressure. They can utter some words, but do not form sentences, and they are able to localize to a trapezius pinch. And then number 3, Paula, can you read number 3 for us? Can you see it?
No, I can't. I'm trying to get my... So the patient's eyes open spontaneously. They are oriented and able to obey commands. So they are spontaneous.
Okay, so what's the answer on this one?
1.
It'd be 2, right?
Oh.
Addison, you want to chime in before I give the answer?
E2.
Okay, the correct answer is 2. The patient's eyes open to pressure, so you pinch them. They can utter some words, but do not form sentences, and they're able to localize to trapezius pinch.
Oh,
That would be the correct answer.
I can't see that page.
That's okay, because here's what I'm going to do. On the share drive, on the next slide, it says you can complete the whole test, all 14 questions of this on your own at www.glasgowcomascale.org self-test.
That's
and there's 14
beautiful.
questions there. So enjoy.
Thank you. That's awesome.
So I found a way to test yourself, and I'd highly advise that you do that. And you're all good people.
You're a good person, Chris.
There's a way to practice.
Really are.
Okay, moving right along. We are now jumping to number 8, spinal cord injuries, which we did not really talk about in class. Okay, we did not really talk about in class, so we're going to talk about it now. So the pathology of spinal cord injuries is in 7 categories, okay, with 1 subcategory under ischial injuries, okay? So trauma, tumors, concussion, contusion, compression, tearing, and ischemic injury. Okay, so we're talking specifically about the vertebral column and the spinal cord. So can anybody tell me anything? What would be trauma to the spinal cord? Somebody give me an example of direct trauma to the spinal cord.
Yeah.
It could be. Okay.
You fall out of a tree and land on a root on your back.
Yeah, that would be direct trauma, correct? So you have direct trauma to your spinal cord.
That'd probably be concussion trauma, right?
Well, yeah, that's just direct trauma, right? You just get hit.
Okay. Oh, yeah, trauma.
What would be a tumor? What would be a tumor?
Metastasized cancer.
Yeah, it's just cancer, right? Like some kind of tumor, whether it's malignant or benign, you're gonna have tumors. Okay. Concussion. What's concussion?
Concussion when you hit the skull, or it's that counter coup. Like
Yeah.
when you
So
shake
remember,
your brain.
so concussion and contusion. Think bruising for concussion. Okay. There's like a bruising pattern going on. Let me look the exact. Okay, so here it is. Let's see. Let me look at the exact definition of concussion.
And for a concussion, you have to pass out in order for it to be a concussion.
Yeah,
Exactly. You have to pass out. You can't say I have a concussion unless you pass out.
Yeah, and there's no gross pathology. A concussion will heal itself. Okay, but contusion's the bruising one, and it will not resolve on its own in the spinal cord. Okay, so contusion's bruising, and what's concussion?
Concussion is just the brain is shaken, right?
Yeah, you just shake it really hard, right? But it's going to resolve itself. And the spinal cord, being an extension of the brain, has the same forces on it and the same injury patterns on it. Okay, and then compression. Who knows what compression is?
Compression when it's kind of something pressed against the spinal cord. So it could be crushed bone, or it's stretched, right?
Yeah, or just pressure, right? You can have pressure on the spinal column. The bones aren't actually breaking, but you're adding pressure to the spinal column, and it's compressing it, and that compression is going to cause some paralysis.
Yeah.
And if the compression's chronic, long term, it can actually damage the neural fibers.
Yes.
Okay, so, tearing force. Addison, what would you consider tearing force?
When the bone is sharp enough to cut it, right?
Well, tearing forces would be like twisting or pulling the top of the bottom of the on the spinal column in opposite directions, right? You're tearing it apart. So, like for example, you're going to see tearing forces. So you could. This is the only time I've ever heard or seen this is,
cutting with a glass, or
metal. You can have direct trauma, right? You can have an impact from a car, right? It hits head on. Like say a car gets T-boned. It's going to be a side impact, and that's going to be direct trauma to the person. But when the car is flipped over and it rolls a couple of times, that's when we get tearing forces on their spinal column, because the car is actually rolling, and the rolling action puts a spin on the impact, and you get a tearing force. Now, let me ask you guys, what do you think is worse on the body? A direct one-directional force trauma or a tearing or shearing force?
Definitely the tearing.
Yeah, tearing and shearing is definitely more traumatic injury, and it's more lasting, and it causes damage over a wider area. It's going to be a worse injury pattern.
What about this analogy for like tearing force? In football, like if you get tackled at the hip and then someone tackles you from the other direction, like at the shoulder.
Yeah,
Your spine goes total opposite directions.
Yeah, you got one impact at your hip driving you one way, and one impact at your torso driving the opposite direction. That would definitely be a good example of a tearing force. Where if you just get hit at the hip, your body all goes in one direction, and your spine recovers from that quicker. Okay. Sorry, go ahead.
A quick question about compression forces.
Yes.
Could a tumor cause compression injury to the spine?
Abso-freaking-lutely, because remember, in tumors, there's more than one process going on there, right? Tumors also secrete hormones. Can those hormones disrupt neural activity?
Yeah, for sure.
So the localized tumor can secrete hormones locally, and the hormones themselves can interrupt neural activity. And then as the tumor grows, then the tumor can cause compression forces as well. So there's more than one injury pattern with tumors that can be caused there, as well as could a tumor be drawing blood flow away from nerve cells and be causing ischemic injury by denying the nerve cells blood.
Yeah.
So there you go. That's ischemic injury. So ischemic injury is where neural tissue is denied blood, and that denial of blood causes the cells to die, and then they go necrotic, and then all the necrotic injury with cell death we already know about.
What's the word for like blood vessel proliferation we learned about with tumors and cancers?
Angiogenesis.
Yes, thank you.
Angiogenesis is what they call that. Okay, cool. And then the bottom note just says with or without vertebra inclusion. So we can get trauma that does not damage vertebrae, but damage the spinal cord directly, we can get tumors that grow in between the bone, impinge upon the spinal column, on the spinal cord, but doesn't damage the vertebrae. Does that make sense? So these different pathologies can happen with or without vertebrae inclusion. Okay, moving along. On the other side, on the right side, it says, where are the most common sites of injury at the spinal cord? C1 to C2. C1 to C2, and then C4 to C7. And then, so who knows what C1 and C2 are called anatomically?
It's
what were those?
axis and atlas.
Axis and atlas. What's the big concern about a spinal cord injury at C1, C2?
The depression of the respiratory.
Yeah, we're above the vagus nerve, right? The vagus nerve is going to be included in that, and they're going to have some definite issues with their breathing and their heart rate and blood pressure and stuff.
Mm-hmm. Yeah.
Okay, so we're good with that. Okay, C4 through C7. Go ahead. Is that Addie? Did somebody ask a question?
No, I didn't.
Okay, C4 through C7. What's going to be the issue with C4 through C7? What do we call that when someone has a spinal cord injury at C4 through C7? There's a word for it.
It'd be quadriplegic.
Quadriplegic. And then T12 through 11, T12 and through L2. What do we call that one?
Hemiplegic.
Yeah, or
paraplegic.
Quadriplegic and paraplegic. So that's what they call
paraplegic.
Yeah.
Right, one side or the other.
Oh, yeah. Okay, let's go through them. Pathologies. Someone named the 7 pathologies.
We got trauma. Tumor.
Yep.
There's concussion, compression, contusion, ischemic, and tearing.
Yep, shearing forces or tearing forces. And then what was the last one? When we deny a portion of the body blood, we call that what?
Ischemic.
Ischemic, right? And then what are the 3 most common sites of injury? Addison, go. Addison.
The 3 types of injury.
The 3 most common sites. The 3 most common sites of spinal cord injury. Hello.
Can you hear me?
Hold on, Sakia. Hello, you there?
Are you talking to me?
I'm talking to Zakia. There you are. You're on. We're on. Everybody say hello to Zakia.
Hey, Zakia.
Hi, Zakia.
So Addison, Alex, and then oh shit.
Holly.
Zara. Oh shit. I'm saying people's names wrong now. Paula, my bad. Sorry. Okay. They're on. So Zakia's on my phone because she's not getting on the computer. So we'll figure it out. But she's on the phone. So yeah. So we're good. Just listen and we'll just keep you involved. Okay.
Okay. So C1, C4 to C7, and T12 to.
So T12 to L2.
Yeah.
Okay, and remember, with the pathology side, all of these injury patterns can happen with or without vertebrae involvement.
Okay.
Okay, spinal cord injury signs and symptoms, they depend on location. This is a review from the previous section. So cervical spine injury, CSI, is quadriplegia. So anything at the cervical level can be quadriplegia, which includes arms and legs. Anything at the thoracic level, T1 to T7 or TSI, is paraplegia, only including the legs or the lower part of the abdomen and legs. And then C1 through C3 injuries require mechanical ventilation. Hala, why do they require mechanical ventilation?
Because it depresses the vagus nerve.
Yeah, it depresses the vagus nerve, and that's what controls respiration.
Yeah.
Okay. Higher level thinking. This is a higher level thinking question for everybody. What can occur when using mechanical ventilation on a patient? What can we do to them?
We can give them too much O2, and they're going to
go. What else can we displace if we're using mechanical ventilation?
We're depressing the bone, it would start and then it's going to crush the spinal cord.
Well, yeah. So when we're using mechanical ventilation, there are 3 gases involved: oxygen, carbon dioxide. What's the third gas that's involved in respiration?
Is it nitrogen?
Nitrogen.
Nitrogen. Thank you. Zakia just got it. So nitrogen. So if we're using mechanical ventilation, we are driving the nitrogen out of their lungs, which when we remove mechanical ventilation, their lungs will collapse.
Because the
do we
nitrogen
remember
keeps it.
respiration?
So
that's the higher. When you hear mechanical ventilation in this section of the neuro, you have to remember that we can be blowing their nitrogen off by giving them mechanical ventilations. So we're all still friends.
So he might get
Atelectasis is the correct term. When their alveoli collapse, we've blown all the nitrogen off. The nitrogen is what's holding the alveoli open with surfactant as the oxygen and CO2 transfer between the alveoli, the outside of the air, and cellular respiration in the alveoli. It's the nitrogen that displaces and holds the alveoli open. And when those collapse, it's called atelectasis. Was that a good review of respiration?
Yes.
Yeah.
Okay, I will try to add those anytime I can.
okay.
I will try to add those every time I see those. And I know you guys hate it when I do that, but I'm going to do it anyway because I think it's awesome.
I
Okay.
do not hate it. I love it.
Okay, here we go. Signs and symptoms depending on location. What was the first sign and symptom? What was the first thing that can happen? At the cervical level, what can happen?
At the cervical level, you can paraplegia.
It's paraplegia, which includes what?
Arms and legs. All
Arms
limbs.
and legs.
Potential mechanical breathing.
Okay, and that would include mechanical breathing if it's at what level?
C1, C3.
C1 through C3, we're going to be we have to mechanically ventilate, and they can go into nitrogen shock if we're not careful.
Hey, can we rewind? If
Sorry.
there is neck injury, you get quadriplegia.
So at the cervical spine level,
Oh, yeah.
so at the cervical spine level, they can be quadriplegia, which is arms and legs. If the damage is at C1 to C3, the injury is going to require mechanical ventilation. And remember, when we mechanically ventilate someone, there's always a chance we're going to blow off all their nitrogen. So when we remove the ventilation, that's going to cause some problems. Or if we're ventilating too much or too hard, we can blow all their CO2 off, which is going to take them to a basic condition, blow their pH. Or if we blow too much or too little oxygen, they can go into hypoxia and acidosis because the carbon dioxide is not getting out, and we're going to put them into a hypoxic condition. They're not going to get enough oxygen, period. If we're ventilating them too slowly or with not enough air. You got a question?
Yeah, the term that's being seen about, I didn't know what is it. It's like DID or DIS?
Atelectasis?
No.
Oh, cervical spine injury, CSI. Cervical spine injury is CSI. Thoracic spine injury is TSI.
Hmm.
Okay.
So if you hear me saying TSI and CSI, I'm talking about spinal cord injury at the cervical level. TSI is spinal cord injury at the thoracic level.
Okay, got it.
Are we good?
Yep, we're good.
Okay. Damn, my stupid second computer. Sorry, guys. My stupid second computer's down. Ah, y'all still there? Okay, so we're good on that part. Okay, we're going to keep going. Okay, we got that piece. Okay, spinal shock. Okay, spinal shock is just a sharp impact to the spinal cord. So, Alex, you used an example before. What was your example before of a good example of when we could get spinal shock?
The tree or the football players?
A football player. A lot of football players and athletes get spinal shock a lot.
Also, hey, Chris. I don't know if it's just me, but I'm still seeing the spinal cord injury slide.
Okay, hold on. Let me get back in here real quick. I'm trying to work 2 screens. Hold on. Stop screen sharing. Now I'm back on. Now I'm going to put this.
Hey, Chris.
How are you?
Good.
Are you seeing my slide now?
Yeah. Okay, there it is.
We're good? So spinal shock, okay?
Yeah.
So temporary loss, somatic and autonomic reflexes below the injury site. So let me ask a question. Who knows the difference between somatic and autonomic reflexes? This is a review from anatomy and physiology.
Somatic is related to the sympathetic and parasympathetic.
Yeah, well, so one is sensory and one is action. One is I'm getting sensation from the body to the brain, and one is I'm sending impulses to the muscles to get to give an appropriate response.
For somatic, skeletal muscle, parasympathetic, autonomic. I don't
Yeah,
know.
so
Autonomic is
somatic
involuntary.
is the muscle movement part, and autonomic is the actual feeling part.
Okay.
Okay, just if you're confused on that, go look those up. Okay, that's a good place to go back and do some review on your own. Go back and look up your somatic and your autonomic reflexes and how neural signals are being transferred from the body to the brain and back. Is that cool?
Yes.
That's an invitation to go review. Okay, the duration of spinal shock is, it should say weeks, I'm sorry. It's 1 to 3 weeks. It should reduce in 1 to 3 weeks, but it may last as long as 3 months. This is what happens when I'm making slides at 2:30 in the morning and I'm tired. I sometimes don't spell the words right. Are you driving a car, Zakia?
I'm not driving.
Okay, I'm like, for hell's sakes, I can see the light poles moving by your head. I'm like, what the hell are you driving? Hey, Zakia's driving and doing study group.
What a
She's
girl.
multitasking. No,
That's either irresponsible or really responsible.
She's in the back seat. Someone's driving her. She's Uber, man. She's Ubering.
Hey.
Sorry, I looked over my phone and I saw like light, and I see light poles going by. I'm like, what the hell
Uber
is she
everywhere.
doing?
Pre-rolls in the whip. Uber everywhere.
Okay, so resolve injury. These injuries usually resolve themselves, and then hyperreflexia can last up to a year. Who knows what hyperreflexia is?
That's if you have like too little calcium.
So yeah, hyperreflexia just means that you get you can't control your reflexes. Does that make sense? You ever seen like old people walk around that have the shakes?
Yeah, and is that as a result of too much calcium? Because calcium is what calms the muscles, right?
Yeah, I think there's a couple of things going on with spinal shock. I think it's due to impact injury to the cells, and the cells start inappropriately secreting
I am doing
electrolytes, and it can last up to a year before it resolves. So again, if we're unclear on that, we may want to review that part too. Okay, we cool?
Yeah.
Okay, so spinal shock. Spinal shock is on page number freaking. Hold on, shiz. Don't listen to me cuss. Don't listen to me cuss. Don't listen to me cuss at anything. Spinal shock is on page number 8. It's it's right in the center. Okay. So who can explain to me the 4 parts to spinal shock?
Say it again.
The 4 areas of spinal shock that we just talked about. Can you guys walk through and tell me what they are? Temporary loss of what?
Temporary loss of the somatic and autonomic.
There you go. Perfect. B, what's B? How long does it last?
1 to 3 weeks or up to 3 months.
There you go. Perfect. And the C was, does this injury resolve itself, or is it something we have to treat?
No, it's resolve itself.
It should resolve itself, right? If we don't continue to traumatize the spine, it'll resolve itself. Okay, and the last piece was
Hyperflexia.
Hyperflexia can last how long?
Year or after.
A year. It lasts up to a year. Okay, we're good. We're moving on. Compression cord syndrome and transected cord. Okay. So, can somebody please explain to me what a compressed cord is?
Sometimes edema because of the bruising.
Yep, edema can cause this.
And can presses against the spinal cord.
Yep.
And sometimes the bone is there is an accident, and then the one of the bone of the spinal column presses against the spinal cord.
Yep,
Does
a shift.
not cut it, does not partially cut it, but definitely press against it. That does not allow the axon send action potential.
Yep, perfect. Transected cord.
It's completely severed.
It's completely severed, and so I gave a little mnemonic to help remember this. Think of a down power line in your neighborhood, right?
Mm-hmm.
When the power line gets knocked over, it's cut. It takes a work crew to come out there and physically replace it.
Mm-hmm.
Okay, compressed spinal cord, it just means there's fluid or some other thing impinging upon it, but it's not actually severed. Okay, between compressed spinal cord and transected spinal cord, which one's worse?
Transected, for sure.
Yeah, that's definitely worse. That's definitely worse because the power line is physically been cut. You want to piss your neighbors off, go cut their power line. Go turn their power off. Okay, so we have compressed and transected. We're moving on. Okay, incomplete spinal injury and complete spinal injury. Okay, look at the titles of those, and in your own words, kind of tell me what's going on. What would be an incomplete spinal injury?
Are you talking to me?
Let's do this. Let's talk about a complete spinal injury, and let's talk about the two. So a compressed spinal injury or a transected spinal injury. Which one is going to be complete? Transected or compressed?
Transected.
Transected.
It's definitely going to be a complete injury because we cannot repair a transected spinal cord, right? Everything below the cut is gone. It's just gone.
Mm-hmm.
And then now we're looking at a palliative care situation where we're teaching people how to live with a decreased level of movement and a decreased level of sensory below that spinal cord transected injury. Okay, what would be an incomplete injury?
Partially damaged.
So yeah, so like, have you guys ever seen like a neuropathy where people can still move their hand, but they can't feel their hand?
Yeah.
So that's like from compression injuries, tumors can cause that, ischemia, where they've had blood flow lost to some areas, only part of the neuron has been destroyed. In this case, it would be it'd be the feeling part of it. Have you ever seen anybody with an injury where they can't move the limb, but they can feel you touching it?
Oh yeah.
So again, a good example of this is like stroke patients. Some stroke patients, they'll lose movement in one side of their body, but they can still feel that side of their body. Other stroke patients, they can't feel or move that side of their body, and that would be a complete injury. And then other patients, they can move those limbs and those parts of the body, but they can't feel them. That's a good example of incomplete and complete spinal injuries. Okay, which one has a better prognosis? Which one do people heal from more?
So partially then.
So incomplete injury, they heal from. Transected spinal cord, they don't heal from that. At least not yet. Give medical science some time. We're getting to where we grow neurons, and who knows? In our lifetime, we may be seeing where we're growing neurons and replacing them, and people don't have complete paralysis. Yeah, stem cell research. I mean, nanites, you name it. We're going there. Okay. So there was a note here at the bottom of incomplete spinal injury. There's a way to test for complete or incomplete spinal cord injury, and it's called the involuntary anal reflex. Involuntary sphincter tightening of the anus. If this reflex is intact, it means that they still have sensory and motor at the level of the anus at the very bottom of the spinal cord, and the outcome for recovery is quite a bit higher for that person, where if that reflex is gone for whatever reason, then their prognosis is quite a bit worse.
Mm-hmm.
So just remember, and this is one of those funny ones, Addison already knows me well enough to know that if I say poo-poo, I get to say poo-poo in a study group. I'm excited. We've just added anal reflux to that group. To say anal reflux, that's like my favorite now.
It's also called the anal wink. So
wink.
The anal wink or anal reflex. So if I get to say anal wink and anal reflex in a study group, that's just made my day. It's the best. Okay. Okay, so in your own words, Alex, will you explain incomplete spinal injury? And as a bonus, you get to say anal wink in this one.
Oh, word. All right. So with an incomplete spinal injury, first of all, the prognosis is better because there's a good likelihood you're going to recover from it. And the baseline is you have some function preserved. whether that be like you can still move it or you can still feel it, or sometimes even both. So like in a neuropathy patient was your example, they can't feel it, but they can still move it, which means only part of that spinal cord is going to be injured.
Awesome. And you didn't say your favorite. What's the favorite word?
Anal wink.
Anal wink.
If anal wink or involuntary anal reflex is intact, then we know that the prognosis is better. If that's gone for whatever reason, that's a negative indicator of good prognosis. They're going to be in a worse way. Okay, Addison, you've been quiet for a while. Explain complete spinal injury to us.
Complete spinal injury is when all the functions is lost or damaged because of it. So it's completely dissected injuries where the spinal cord is completely severed.
That's it. And you don't have the anal wink.
No
We
anal
don't have the
wink.
anal.
There's no anal wink intact. That's an awesome word, man. I love it. Okay. So, hey, everybody, that's it. That's all I have for us tonight.
Hey, thank you so much.
You guys-
I'll see you again
thank
at
you,
9:30,
Chris.
okay?
Yeah, I'll be on again at 9:30. I'm hoping to get some more slides added for 9:30. But if I don't, we'll just get a good review of this and we'll just keep moving forward.
Yeah, you're one heck of a guy. Thank you so much.
Okay.
Yeah,
We're all
thank you,
good?
Chris.
Okay, peace out, Zakia. I'm going to be on again at 9:30. So if you want me to add you, I will.
See you at 9:30.
Okay, see you all later.
See you, Chris.
Okay, bye. How do I shut this? Damn it. There we go. Is anybody still on?